Hello, well, welcome to this Cytokine Signalling Forum webinar. My name is Chris Edwards. I'm a rheumatologist in Southampton in the UK, and it's a real pleasure to have you. Thank you for registering. Thank you for being part of this meeting. And thank you to those of you who sent in questions already in advance. And I'll just remind you to send in questions as we go along, and I'll have some housekeeping to tell you exactly how to do that shortly. Okay, so it's a real pleasure to be joined by my colleague Georgi Nagy. Georgi, hi, thank you for joining us and being part of this meeting. And I'll introduce Georgi in more detail in a moment when he comes to present some of his slides. But what we hope we'll do over the next hour is to show some slides, discuss, interact with questions from yourselves and also questions between each other. Around this subject that we're going to look at, which is around measuring in rheumatoid arthritis. Okay, so here are some disclosures for myself and Professor Nagy as well, and I'll just let you see those just for a moment. Okay, so here's some housekeeping, and this just makes it easier for you to know where to ask questions that are technical problems and where to ask questions if they're questions to ourselves and the panel for discussion. So you can see on the toolbar that there are a couple of different ways of doing this. So Q&A are for the questions to us, the clinical questions, the scientific questions around the presentation and the discussions we're having. But if you have problems with the system and it's a technical question, then you can see there is a chat function that you can use over on the right-hand side of this slide as well. So those two ways of doing it. And once again, just encouraging you to ask questions as you go along, which we'll deal with some as we go through the presentations and some at the ends as well. And this is what we're going to do. So measuring rheumatoid arthritis in practice is the subject. And I'll tell you sort of the thinking behind that in a moment. I'm going to talk a little bit about measuring rheumatoid, some of the things that I'm interested in around which measuring systems we might choose, what we use in our own hospitals, in our own countries, and some of the pitfalls around that, particularly in relation to how the patient experience, those subjective measures, pain, for example, influence those scores, and how that gives us a wonderful opportunity to then think about managing difficult to treat rheumatoid arthritis. And Georgi will tell us about this, but some of difficult to treat rheumatoid will be inflammatory disease that we can't control. And some of this will be more patient-related factors that are influenced by pain and fibromyalgia-like phenotypes and depression, all very important aspects of the patient experience of rheumatoid arthritis. And then we have time to have a chat at the end and discuss the things that we've been talking about. Okay, so now we're going to go on to the first of my slides. So let me tell you about the thinking about this. So we all measure, and we'll talk about why we might measure rheumatoid arthritis. And it's important for many of the strategies that we use now when we're treating rheumatoid. But there are some very important aspects of this. So the choice of measuring, what particular scoring systems we use. And one thing that I'm going to go back to again and again is this business between there are objective measures, for example, swollen joints and the ESR or CRP, and there are subjective measures, the patient global experience and the number of tender joints. And it's really important of course, to look at the constituent parts of any scoring system and understand when things are being driven by both objective and subjective measures, or more by objective and more by subjective. And that allows us to lead into thinking about the influence of pain on these scoring systems. And then that allows us to think about difficult to treat rheumatoid arthritis, which is why we're so lucky to have Georgi joining us today. Okay, so why measure? Some of this is pretty obvious, isn't it? But if you look on the right-hand side, there are various strategies that we now use, which have been established over many years to treat patients with rheumatoid arthritis. We want to treat early. We want tight control. We set a target. And then, of course, we have a number of different therapeutic choices as well, which interestingly, those different choices might influence the scoring systems more or less as well. So, for example, if we have something that has a strong influence as a treatment on C-reactive protein and interleukin-6, that might influence scoring systems that also include CRP and ESR, for example. Now, many of those strategies require us to score. And I suppose it's no big surprise that when we're managing patients with any disease, and the blood pressure doctors know this, the diabetic doctors know this, we have to set targets, we have to pick a scoring system, we have to follow that over time. So one reason for measuring is to assess disease activity. How badly is a patient doing at that moment, and how much do I need to do something? Another reason to measure is to be able to set a target. What are we aiming for in the long run? When do we reach a destination where we say this is good enough and we don't need to push harder because we think this is controlling the disease well enough? The other reason we might measure is to look at flares when someone is doing worse and to try and understand what sort of flare that is. And that comes to, is it more pain? Is it more inflammation? Is it a bit of both? And then there's sort of the dirty practical reality of measuring as well, which is around to be able to use therapies in many of the environments we work in. We have to be able to show that a measure, a score, is bad enough to be allowed to use a particular therapy. And so within the United Kingdom, for example, for advanced therapies like biologics and JAK inhibitors, we were only up until fairly recently allowed to treat those patients if they had severe disease as defined by DAS28. More recently, most of these have been, or many of these have been allowed for moderates as well. So a number of different reasons, but there are some pitfalls that we'll go through in a moment. So where can we find out about measures? And here's a little advert for a really good resource, which I use. This is on the EULAR website. You can find it. It's the EULAR Outcome Measures Library. And you can look at the front page here that I've shown on the slide, and you can search. So I searched here rheumatoid arthritis, tick the English box as well. And then on the right-hand side, you can see Outcomes Clinical Disease Activity Index, DAS28 score, etc. You can read down, and then the more patient-orientated, rapid scoring systems, for example. But this has information about what they are, what the background is, what the references are, and also how the equations work and how the scoring systems work. So these measures. Now, one of the things I always forget, and in a UK setting, in the hospital I work in, DAS28 is what we use most of all, and you can see those criteria. So those are pretty much fixed in my mind, for remission being below 2.6, low disease activity, moderate and high. And I always have to think a little bit more for SDI and CDI because I don't use that so much, and you can see those boundaries there. And I was just going to ask Georgi, so in your setting, Georgi, which disease activity measures are you using most often in the clinic?
We are using DAS28 in the everyday clinical practice, yep. The ESR-based DAS28, and okay. In Hungary we need it for the prescription of all targeted therapies. So we must determine DAS28 in each time when we see the patients.
Okay, great. And I think it'd be true to say there are differences, aren't there, in different parts of the world and in different countries, yeah, where people have selected one or another. Okay, so I'm going to move on to the next slide. Thank you for that. So here are the component parts in some of these measures. These things are worth just having a little look at. So in trials, traditionally ACR20 was used often as a primary outcome measure. Of course, that's a do you achieve 20% improvement or not? And of course, there's an ACR 50 and an ACR 70, and has all of these components that you can see listed on the left-hand side. DAS 28 has the patient global, tender swollen joints out of 28, and the ESR or CRP. SDI also has the physician global. And then CDI skips ESR and CRP. And one of the strengths there is around maybe looking at therapies that have a very strong effect on IL-6 and therefore on CRP and ESR. And then RAPID is, I don't really have much experience of using this beyond some research situations, but ways of monitoring patients which doesn't require them to be in the same room as a doctor has been really important over COVID. And so I guess some of these scores have had more attention as well during this time. Okay, so those are the measures, and I've shown the component parts, but of course there are many other things that we might want to capture. We're not sure those scores fully capture the patient experience. You might use radiological markers and using ultrasound, using the OMERAT scoring systems for synovitis, for power Doppler, those might be useful as well to measure disease activity. We could measure cytokines and inflammatory markers. And for a more patient orientated set of measures, we could use pain scores, other PROs as well. And then brain scans I put in because I'm going to show a little bit of work about brain scans in a moment. And that's around thinking about how we measure the effect of systemic inflammation and pain on the brain, and whether we can show with functional scans some of that. Now, when people use measures, one of the reasons they use measures is to define remission. And I guess because I use DAS 28 most often, less than 2.6 DAS 28 ESR is what I'm usually thinking about. But if you look, this is some work from the Danish colleagues and from the Dutch colleagues on the right-hand side. Those patients achieving remission 6 months. If we look at the right-hand side at the DREAM registry in the Netherlands, you can see 27% achieving remission if we use DAS 28 ESR less than 2.6. But then we've got this really strict remission criteria, which is ACR Boolean, ACR EULAR Boolean, and that's about 1 or less swollen joint, 1 or less tender, 1 or less on the CRP. So it's much stricter, and it depends what we're trying to achieve. So we'll get less people, but we know that remission is much more likely to be a much deeper, more definite remission, if you like. Okay, so now coming back to some practical things. And I'm going to ask Georgi in a moment on the next slide his view on this as well. So here's an example about a patient. So this is a real patient from Southampton. So 65-year-old man, rheumatoid for a long time, lots and lots of different biological therapies used, and actually over a fairly long period of time. So not just cycling every 3 months, but very difficult to treat. And if you look at the DAS 28, 5.7 when they were seen, when they were assessed, ESR 37, so that's up a bit. Swollen joint count, they're only 1. Lots of tender joint counts, and the patient global, the VAS, really, really high. And I suppose depending on who does the scoring system, it comes to that idea of, I've always had this dream of having a DAS 28 score where it's almost like a heads-up display, and the relative contribution of each part of the score, subjective and objective, is shown to you, so you understand that as you're seeing the patient. So here's another example. So I've just played around with some imaginary figures here. So here's DAS 28 5.22 in 2 patients, so severe disease activity. So the top one, patient 1, ESR 18, so lowish ESR, swollen joints none, tender joints loads, patient global assessment 90, versus patient 2, ESR 50, so some inflammation, swollen joints 7, less tender joints, and the patient global is quite high. So I wonder if you look at these. So if I was to put one of these patients onto a biological therapy, which one you think is more likely to respond, and which one is more likely to become the difficult to treat rheumatoid arthritis? I don't know, because I look at this and I think, well, perhaps the one on the bottom has got more inflammation driving this, so they're more likely to respond to therapies that, after all, are designed to treat inflammation. What do you think?
I can give you 2 different answers for this question. So the first is the obvious, what I think we can see, that these 2 patients are quite different. The first patient, the ESR is not so high, but the tender joint count is really high. So probably the inflammation is higher in this case. In case of the second patient, the tender joint count is not so high and the ESR seems to be higher. So both might be difficult to treat. I would say that to make and to find out the reason of being difficult to treat I guess in the algorithm, but I will present. So my suggestion is that we can guess. We may guess that patient one seems to be maybe more difficult to treat with the same DAS28 or may not be. But the reason why we created this algorithm, which is really a clinical roadmap, which I would like to present, is I think the more appropriate answer for the question. So let me to present that.
Fantastic.
In the second part of this presentation, and then we will see if it works.
Okay. So I think that's a really good signposting to the algorithm that you're going to show. And also, I guess it's also suggesting there's a danger in my attempt to be too simplistic and to say, there's a definite answer one way or another.
I would say so.
Okay. So some other things to think about. So I was going to bring pain in here, and that was one of the areas that I particularly wanted to bring out. And I know Georgi is going to mention some things about pain later as well. So here's the Swefut study. This is a Swedish study. This is looking at patients given methotrexate and then given a couple of different treatment options. But that's not the most important thing. What's the most important thing is, if you look at time zero over on the left-hand side, 76% of individuals have unacceptable pain with inflammation. If you look there at 24 months, so 2 years later on the right-hand side being on the trial, so now we've got 77% of individuals have no or acceptable pain. And then we've got this 23% who have unacceptable pain, of whom about half still have inflammation. And maybe in my simplistic thinking, you think, well, I'm going to give stronger anti-inflammation therapy. I'm going to use a different mechanism of action, biologic or a JAK inhibitor, for example. But then there's that 12% of people, unacceptable pain despite inflammation control. And the reason for thinking about this is the effect that has on the measuring systems that we use. Another way that's been important is, I mentioned earlier that in a UK setting, that we've been in a situation of not being able to offer biological therapies or JAK inhibitors to patients with moderate disease for many years. And when people started thinking about being able to use in moderate, which now we can do for most of the therapies, people started to worry, are there a group of patients that have more inflammation for whom this is a good thing? And are there people that perhaps their disease is more driven by pain for whom this may not be such a good thing? There should be other strategies that should be used. And these three factors here come from a systematic literature review where we looked at what predicted poor outcome radiologically and also in terms of further disease activity. And it's having the top end of moderate disease activity, more than 4.2, having anti-CCP, not surprisingly, and having ultrasound evidence of disease. So this comes back to there are other measures that might help us to unpick what's going on as well. Okay, so let's move back just to thinking about rheumatoid as a disease and the different component parts. So this is the scientific slide, isn't it? This says cells and cytokines are important. And it reminds me to say that when we're designing therapies, we're designing them to inhibit these pathways, the cells, the cytokines, the signaling pathways. So it might not be a surprise if we're aiming here that we're less good sometimes with our therapies at treating other parts of the disease from the point of view of the patient experience, such as pain. So here's the total experience of rheumatoid arthritis divided up into these parts. Here's the scientific bit, the inflammatory joint disease, which I've just mentioned, pulled out as a slice in the pizza. But you can also see there are other important parts of this, the pain, the fatigue, mental health related problems, cognitive function, the social interaction, for example. And when we're thinking about measures, we might think that we need different measures to measure some of the different parts of the patient experience. And this is a nice piece of work. I'm going to show a couple of slides from David Walsh in Nottingham. Here's one of them. And this is a conceptual slide. And this says, okay, here's the top part of the slide thinking about rheumatoid arthritis. Certain genes are important. certain comorbidities are associated with rheumatoid. And over time, inflammation through early and established rheumatoid can lead to the inflammatory problems that can lead to structural change. But then he makes the point that a patient's pain in rheumatoid may be part of these rheumatoid pathways, but might also be separate. There may be different genetics. There may be different risk factors for pain superimposed, which may make it more likely that pain is sensitized centrally and peripherally in experience. So different measures may be required for different systems and different approaches to treatments as well. And this is the second of David Walsh's slide. And this is something we've been playing with in some of the studies we've been looking at in our biological database and some of the tapering work that we've been thinking about. And this is this concept of a DAS28 pain. And there's a terrible looking equation there that you can look at. But essentially what this does is it tries to demonstrate the proportion of the disease activity score, so the DAS28, that is as a result of the subjective, those patient experience measures, the tender joint count and the general health visual analog scale. And that has been shown to predict response, for example, to TNF inhibitors in the biological registry in the UK. But it's a way of trying to assess this difference between subjective and objective. Now, at the start of the presentation, I mentioned that I was going to show you some functional studies. And actually, this is a lovely study to have a look at. You can see the reference there and to spend some time looking at. But if I was to really simplify it, this is a scanning study of patients with rheumatoid, looking at the effect of inflammation on their brains. This looks at structure and it looks at function. So structure, the size and the shape of different parts of the brain. And then function you can look at in a couple of different ways. One of the ways you can look at is the different neural pathways between different bits of the brain. And this study allowed a demonstration that different bits of the brain could be different shapes, sizes, and that different neural pathways and interactions can exist more after the exposure to inflammation that occurs with rheumatoid. And it starts to make you think that I was dividing up objective and subjective measures, and Georgi was perhaps warning to be a bit more careful and to have a think about the nuances of this. And it might allow you to think of a couple of different situations. So it could be that pain that influences a measure is completely separate to inflammation in a patient. Or it could be that chronic inflammation changes the brain in some way and the experience of pain. And the thing I'd love to know is I'd love to see, maybe it's been done already, is this study then done having controlled those patients really well with really effective therapy to see whether the brain changes back to its pre-morbid state or whether these things become fixed. I think that would be a very helpful thing to use. And I guess with the complexity of most things in medicine, it will probably be a mixture of both. Okay, so at this point, I'm also going to just remind you to send in some questions to us. If you have questions that you'd like us to address, to deal with, it would be wonderful to see those as we go through. Okay, so then I'm not going to say too much about this. So one of the really nice reasons to have Georgi with us today is because he's first author on this EULAR definition of difficult to treat rheumatoid arthritis paper, the reference on the bottom there. And he'll go through this in more detail, but essentially it's this dividing up the patients into difficult to treat on the basis of these three criteria. So people have failed treatment, people have ongoing disease, that's the middle one, and at the bottom they have signs and symptoms that bother the rheumatologist and or the patient. So we'll hear about those in more detail. But in thinking about measuring, this played into this thought around the way pain changes some of the measures we use, how we must be careful to think about the subjective and the objective components, and what we might do to try and assess which patients might fall into that difficult to treat group and whether there are different approaches to treatment. Okay, so here's the summary at the end of my few slides. So we use measures of disease activity for a number of different reasons. We want to set a target, we want tight control, sometimes payers require that. We need to include the patient experience, but we might need to understand that different therapy and different approaches are needed for different types of disease activity, whether it's more driven by inflammation or more driven by pain secondary to inflammation or independent of inflammation, for example. And Then we lead on to this idea of why rheumatoid arthritis is difficult to treat in some patients, how much of that might be difficult to treat inflammation, how much might be related to pain, and how much might be related to other factors as well. And then there are other new measures that we might use in the future, such as imaging of the brain. Okay, so that's the end of my slides. And now, Georgi, perhaps we could come together just for a moment to have a think about that. So we talked a little bit about using DAS28, which we both used. Do you run into any particular problems? Did this difference between subjective and objective measures within the score chime with you? Do you take the score as a whole, or do you always look at the individual parts?
Yeah, definitely, every day. And that's also part of the difficult to treat concept, that if you take a look at the definition, you will still be able to pick the patients who have, for example, joint problems other than those which are included in DAS28, for example. But another important aspect is that rheumatoid arthritis patients may have active disease in other sites than the joints. For example, interstitial lung disease or central nervous system involvement, etc. And our definition would capture those patients as well. And I think this particular topic needs much more attention than it received recently. For example, interstitial lung disease, there are so many publications recently. So that's another thing, that how can we judge and evaluate joints really in the most appropriate way, not only the 28 joints, but all of them, which are important in the aspect of RA, and also the extra-articular manifestations.
Yeah, and I suppose that there are two things that I think about as a result of that. We've had some really smart podiatrists work with us over the last several years and have done PhDs in Southampton. And they're always concerned about the fact that DAS28 excludes the feet. So that's one part of it. And when you have really involved feet, do you count that and include that as one of the finger joints just to get it within the score, for example? And then the other bit it made me think about is in relation to interstitial lung disease, it's perhaps a call to have a score that is more reflective of measuring the total experience of rheumatoid disease rather than just joint disease, because we've spent much more time, I suppose, with a DAS28 thinking about its rheumatoid joint disease. So maybe we should be going the way of psoriatic arthritis and of lupus, where we're looking at lots of different areas of disease activity as well. Do you think that's a way to go, or do you think that might cause different problems?
Yeah, I think that's the way to go, and to have a
more complex system. You think
more complex assessment, and that's what I will try to emphasize.
Fantastic. And then there's just one other thing I wanted to ask you in relation to my talk. So there are different definitions of remission. If you look at the EULAR recommendations, for example, it will say the target is sustained remission, but low disease activity is pretty good as well. And do you think that definition of remission we're aiming for, we always need to be aiming for the Boolean, which is a small number of people? Or do you think if we push too hard for that, there's a danger in becoming obsessed with that target?
I think that's a tricky question. Yeah, but I think that the EULAR recommendations provide a clear answer for that question when it says that remission or at least low disease activity. So I'm confident that we cannot reach remission, and especially Boolean remission, in every patient, and that I also will talk about, especially in case of difficult to treat patients, sometimes low disease activity is much more realistic than deep remission. And that's also included in the EULAR recommendations, which is led by Professor Smolan.
Yeah. Okay, that's exactly right. And I guess it's living in the pragmatic world. Right. Okay, so let's go back to the slides, because I have a slide there, I think, to introduce you, Georgi, more formally, although you've been chatting away. Well, actually, I can introduce you on this first slide before you start. So Professor Nagy, you've heard him already on this particular webinar, but thank you very much for joining us. Georgi is a professor at Semmelweis University in Budapest in Hungary. He has a number of interests, has spent time in New York, is particularly interested in inflammatory disease, inflammatory joint disease, but he's first author of this paper that I've mentioned already, which is difficult to treat rheumatoid arthritis as defined by a EULAR task force. So Georgi, thank you very much.
Thank you so much for for the introduction, and thank you so much for the possibility. It's really my pleasure to be here today. And so I would like to shortly explain the concept of difficult to treat rheumatoid arthritis. So basically, as you all know, and I hope that you can hear me and see me. Is this correct, Chris?
Yep, I can hear and see you perfectly.
Thank you. So basically, we are using the EULAR recommendations and ACR guidelines for rheumatoid arthritis in the everyday clinical work, and then I think that they are especially useful. But still, we have plenty of patients who cannot reach sustained remission or low disease activity. At least 20, 30, sometimes up to 40% of patients are refractory, and they represent a significant problem. Therefore, we decided some 7 years ago to create a new task force and to try to find a new way how to treat these patients. So we decided to create a terminology for these patients, a definition of these patients, and also to create a guidance for the comprehensive management of these patients who cannot reach remission or low disease activity by identifying the reasons. And that's what you already asked, that's what I think. And I hope that I will be able to explain and how to adjust the pharmacological treatment options and consider non-pharmacological treatment options as well. And from the very beginning of this project, we really tried to create something what is fully complementary and in line with the current EULAR recommendations and ACR guidelines for the management of rheumatoid arthritis. So basically, we thought initially that somehow we should deal, when we talk about the definition of this patient group, we should consider the treatment history, and somehow we should include in the definition, and as you will see, this was done, somehow the measurement of disease activity and other signs or symptoms of active disease. Initially, it was considered that glucocorticoids might be useful, glucocorticoid usage might be useful to include in the definition, as well as the radiographic progression and the symptoms which are still influencing the quality of life, because some patients have non-inflammatory disease activity. So that's the last part, which I will come back a little bit later and explain in more detail. Try to include those patients which patients have non-inflammatory symptoms. And we, from the very beginning, we thought that it will be very important to really catch the problematic patients based on the opinion of either the rheumatologist or the patient. So basically, I will go through the terminology, the underlying factors, very shortly the results of an international survey, the definition, the newly published guidance, and some aspects of the JAK inhibitors in rheumatoid arthritis. What about the terminology? So we considered a lot of different potential names for this patient population, including multi-drug resistant complex, refractory, therapy resistant, and so on, and difficult to treat. Finally, difficult to treat was selected because it reflects best the clinical situation, and all task force members clearly agreed on that. And difficult to treat is really used in other specialties, including pulmonology, like difficult to treat asthma, or in cardiology, difficult to treat hypertension, or in infectious diseases, infectology, such as difficult to treat infections. If you just type in the PubMed difficult to treat, you will see a large number of hits for various diseases, and now you will see plenty for difficult to treat rheumatoid arthritis, which we really hope that will increase significantly in the future as well. What are the underlying factors? So if we say that comorbidities, behavioral factors, failure to different kind of therapies, and rapid radiographic progression all are important potential components of difficult to treat, I think you would agree. What about comorbidities? Because some comorbidities may limit treatment options or fuel inflammations. For example, infections, malignancies will actually fuel the inflammation big time. Lung diseases, chronic heart failure, kidney failure, and so on are conditions which may limit treatment options and so may contribute to the inflammation and accelerate the inflammation. There are some non-inflammatory conditions as well, which may represent a significant problem, such as fibromyalgia or depression, which also may contribute as comorbidities to difficult to treat disease. You should also consider behavioral lifestyle factors. It is important to recognize if the patient has non-adherence or non-persistence to different medications. Socioeconomic factors, for example, obesity, overweight, smoking, alcohol consumption, and so on, as well as the management goals and the patient coping strategies. I think it's not really necessary to explain in details that failure to different kinds of medications, including conventional, synthetic, targeted or biological DMARDs, are very important aspects of difficult to treat rheumatoid arthritis, and sometimes biological DMARDs promote the generation of anti-drug antibodies, and these anti-drug antibodies are a potential reason of difficulty in treatment in case of biological disease-modifying drugs, and rapid radiographic progression is obviously another potential reason of being difficult to treat. And this rapid progression happens frequently in the context of failure to different kinds of medications, but may also happen sometimes if the disease activity is not so high, measured by DAS28, as it was mentioned by Chris. So that's why it was considered separately as well. And all these reasons, all these factors may coexist and, may represent a real clinical challenge in the everyday practice. So let's see the results of an international survey, which was conducted a few years ago. And the reason was that we thought that it would be very important to receive input from clinicians, what they think about this concept, what aspects would they include in difficult to treat patients. And this is just how many responses we received, 410 from 33 different countries, and we received a high number of responses for this online survey from Czech Republic, Hungary, Germany, and United Kingdom. So if any of you who are here with us today in this webcast completed this survey, thank you so much to do so. So we had a lot of questions in this survey, and I just would like to highlight some of them. For example, we asked our colleagues what they think about the potential disease activity which is associated with difficult to treat disease, and here this blue option was the most selected one, which says that DAS28 higher than 3.2, or the presence of signs suggestive of active inflammatory disease activity if the DAS28 is lower than 3.2. This was the most selected option, and here I would like to refer to Chris's previous question. So if there is joint activity in joints other than those included in DAS28, that may also represent a significant problem, obviously, in rheumatoid arthritis. The next one is the treatment failure history. So here the green option was the most selected one, which means that if a patient is over at least 2 conventional synthetic DMARDs and at least 2 biological or targeted synthetic DMARDs with different mechanism of action, that was the most selected by the respondents. And the second most selected was a similar one with 3 different kind of targeted therapies. So we also asked about the treatment with glucocorticoids, if it should be included in the definition or not. So we here again had several options, and the most selected one was unable to taper below 10 milligram methylprednisolone or equivalent, or unable to taper below 5 milligram. And some patients or some colleagues suggested to use another dose or not to be mentioned in the definition. But as you see, most colleagues suggested to include the dosage of glucocorticoids in the definition of difficult to treat rheumatoid arthritis. And another, I think, very clinically important question is if fatigue should be a part of the definition or not. And here, most colleagues suggested not to include, as you see, 58% and only 42% suggested to include fatigue in the definition of difficult to treat rheumatoid arthritis. I think here the reason is that most colleagues did not suggest to include fatigue is that they believe that it's so common in rheumatoid arthritis in all forms, including difficult to treat, that they were not sure that it will discriminate our patient population from other patient populations. So here we had the basis of the difficult to treat definition, and here you see the definition. Actually, this is what Chris already showed us. So we basically, in the EULAR definition, which was published in the Annals of Rheumatic Diseases some 1.5 years ago, had 3 different parts. Actually, the survey was also published in the Annals of Rheumatic Diseases 4 years ago. The first is regarding the treatment failure history. So the patient should be over at least 2 biological or targeted synthetic DMARDs with different mechanism of action after failing conventional synthetics. Here it's important to emphasize that in case any of these medications are contraindicated, then that particular criteria is not applicable. So there might be medical, socioeconomic reasons, or if the medications are not available for any other reasons, not applicable. The second part of the definitions have 5 parts, and any of them would be enough to meet the definition of difficult to treat rheumatoid arthritis. So first is at least moderate disease activity according to validated composite measures. These were discussed in the previous presentations. The B is signs and symptoms suggesting of active disease, and I would like to refer again to the previous presentation and discussion that if a patient has interstitial lung disease or other extra-articular manifestation, that might be a significant problem as well and might suggest active ongoing inflammation, what somehow we should deal with. Inability to taper glucocorticoid, this is a middle dose 7.5 prednisolone or equivalent, which is 6 milligram methylprednisolone. Rapid progression is the 4th. And the last one refers to non-inflammatory symptoms, which says that the disease is well controlled, but the patients still have significant problems which are causing a reduction in quality of life. So any of these 5 sub-items is enough to meet the criteria of difficult to treat disease. And the third point is basically what was mentioned by Chris and myself as well, that the management should be problematic by the rheumatologist or the patient. Otherwise, that by definition is not difficult to treat. So the first, one of the second and the third should be met to say that the patient has difficult to treat disease. And if the patient has difficult to treat disease, what to do with them? And that was the next part of our journey, EULAR journey, then when we created a guidance for these patients, and I would like to go through this guidance real quick. As you know, in the EULAR management recommendations, they are generally overarching principles, which we have 2 A and B overarching principles for this particular topic, and it says that these points to consider pertain to patients who fulfill the definition which was just detailed for difficult to treat rheumatoid arthritis and underpinned by all EULAR recommendations for the treatment of rheumatoid arthritis, including the overarching principles. So this is basically the bridge between the main EULAR recommendations, and so our work is a supplementary part of that particular recommendations and should be used together with the EULAR array recommendations. The second overarching principle is, I think, obvious, and we should consider this always, that inflammation should be established to guide all kinds of treatment, including both pharmacological and non-pharmacological treatment. Let's see the specific points real quick. First of all, if a patient has assumed difficult to treat rheumatoid arthritis, then the possibility of misdiagnosis and or the presence of coexistent mimicking conditions should be excluded as the first step. So I think this is hierarchically the first thing to do, but I will come back a little bit later very quickly. So we should reconsider the diagnosis as the first step. And then the second is, if there's a doubt on the presence of inflammatory activity based on clinical indices, that we should perform ultrasound. I think this is self-explanatory as well and done in the everyday clinical practice. That's what we do. The third point is that composite indices and clinical evaluation should be interpreted with caution in the presence of comorbidities. I already mentioned that comorbidities are one of the most frequent underlying factors of difficult to treat rheumatoid arthritis, and here we highlight obesity and fibromyalgia because they may directly heighten inflammatory activity. The fourth point here is treatment adherence, which is very crucial in the context of all chronic diseases, including rheumatoid arthritis, should be discussed, evaluated in the process of shared decision making. For the fifth point, we come to pharmacological therapies, and this point says that after the failure of a second or subsequent biological or targeted synthetics, and particularly after two TNF failures, treatment with a biological or targeted synthetic with different targets should be considered. And this is very nicely complementary to the EULAR recommendations as well. And if you wish, we may say that we really try to encourage clinicians in case of difficult to treat rheumatoid arthritis to change, to switch to another targeted therapies with a different mode of action. The next one is if a third or subsequent biological or targeted is being considered, the maximum dose which is safe and appropriate should be used. And here we consider tofacitinib and baricitinib, which has different licensed doses. Tofacitinib used to have one, but it's not labeled anymore, only the 2 times 5 milligram, but tocilizumab and baricitinib has different doses. In the original version of this recommendation, the drugs were included, but in the updated version, we decided not to include any particular drug names, but in the text which is joined to this recommendation, you can read that this is regarding baricitinib and tocilizumab. Currently, the seventh point is regarding comorbidities that may impact quality of life, should be interpreted with caution and carefully considered in the context of difficult to treat rheumatoid arthritis. The next point is regarding hepatitis, which has quite a literature. So in case of concomitant hepatitis B or C infections, then D or targeted synthetic DMARD or biologicals can be used, but antiviral prophylaxis or treatment should be considered always. And the ninth point says that in addition to pharmacological treatment, which was detailed so far, non-pharmacological interventions such as exercise, psychological education, and self-management options should also be considered. And it is similar. Next point further emphasize the appropriate education and support, which should be offered to the patient if the patient has difficult to treat rheumatoid arthritis, as well as the last point, which further emphasizes the importance of offering self-management programs, relevant education, and psychological interventions as well, if it's needed, to optimize patients' ability to manage the disease confidently. So, and we created several figures which try to summarize the clinical roadmap, and this particular one was selected. So if our patient, and I really hope that this figure can be used in the clinical practice, if our patient has difficult to treat rheumatoid arthritis as a first step, and here the letters represent basically the overarching principles and the numbers, the particular points to consider. So first we consider the diagnosis and then go step by step on the recommendations. If the difficult to treat is confirmed, then you should reassess the diagnosis and then go step by step and try to rule out other conditions and then estimate the real disease activity, also the comorbidities in the context of rheumatoid arthritis, and if arthritis activity is present or not. If you are not sure, please use ultrasonography. And if there is no inflammatory disease activity, please do not escalate DMARD therapy. It's even included in the text that consider tapering, which was decided not to include in the figure, but you will find that statement in the text. And go to the last points, which suggest to use non-pharmacological treatment options. But if there is considerable inflammation and the diagnosis is correct, and we went through all the points which were mentioned, then please evaluate treatment adherence. And if there are no adherence problems, that's the patient population where you should consider to either intensify or switch DMARD therapy and manage comorbidities that may limit treatment options. Otherwise, come back here and again optimize treatment adherence if there are adherence problems. And again, in all cases, please consider using non-pharmacological treatment options as well in all patients. So I would very shortly like to emphasize our recently published data regarding inhibitors in rheumatoid arthritis. This is just the the map how we try to do this meta-analysis regarding patient-reported outcomes in rheumatoid arthritis. This is a systemic review and meta-analysis of more than 24,000 patients. So a lot of literature was searched, and basically just the main results. Here you see always improves with placebo or improves with JAK. So this slide shows the JAK inhibitors compared to placebo. Obviously, the ACR responses are much better in case of JAK inhibitors than placebo. And here, if we come back to pain and physician and patient global, again, we had a much better response with JAK inhibitors than with placebo. Probably more interesting to see what happens if we compare JAK inhibitors with methotrexate. Again, we have a much better ACR 20, 50, 70 responses and death responses and so on. And we also had a much better response than methotrexate in terms of HAC response and also in terms of SF36 and FACIT response, which are patient-reported outcomes. And I think the most interesting might be if we compare JAK inhibitors with BDMARDs, biological DMARDs. So here again, we have better responses in terms of ACR 20, 50, 70, SDI, DES28, and so on. And if we compare the efficacy of JAK inhibitors on the pain, physician and patient global assessment, again, with JAK inhibitors, we had better responses than with biological DMARD. So we may say, and I think that Chris also suggested this, that pain in the context of inflammation is very complex. There is pro-inflammatory cytokine release in the periphery, which by itself may trigger pain by the immune system and by setting up the threshold of pain also in the central nervous system. But there are other ongoing relevant processes in the CNS as well, which include pro-inflammatory cytokines as well. And altogether, this pain processing mechanism will ultimately define the pain and the pain feeling, but I think we do not understand very much in details, but we know that some factors are directly related to inflammation and some others are not. But this, I think, deserves further research as well. So I try to discuss the terminology, the underlying factors of difficult to treat rheumatoid arthritis. The most major ones probably include comorbidities, behavioral factors, drug-resistant disease, and rapid radiographic progression. I try to summarize the published international survey, the EULAR definition, the EULAR guidance, and also a recently published JAK inhibitor meta-analysis, which suggests that in terms of patient-reported outcomes in many aspects, JAK inhibitors seem to be more effective than other targeted therapies including biologicals. I just would like to mention that the Difficult to Treat project was supported by EULAR, and you can find all details in 5 publications, which include the systemic literature reviews, the survey publication, the definition, and the points to consider. Zoltán Szekanec, Melinda Kedvek, Attila Hamar contributed a lot, such as Jaap van Laarhoebas, convener, Paco Welsing and Desiree van der Heijden, methodologists, and Nadia Rodendries, another fellow who worked really a lot for ages on this project. And another meta-analysis was conducted by Lilla Tóth, my PhD student, many other colleagues, and Zsuzsanna Helyek contributed significantly to this work as well. And thank you very much for the possibility again, and thank you so much for your attention.
Fantastic, Jorgi. Thank you so much for great presentation. And it's lovely to think our way through rheumatoid, measuring rheumatoid, defining this group of difficult to treat, and then thinking about who within the difficult treat we could have picked up from those measuring scores. So one of the things I wanted to ask you is, was there a group of difficult to treat patients that was the predominant group? Are most patients failing to be controlled because they have comorbidities, or because they have uncontrolled inflammation, or because they have depression or pain problems? Did you have a sense of what the biggest is?
I do have a sense, but I do not have appropriate data to answer this question. I think that there are some publications already and many other works ongoing, to estimate the underlying factors in different patient cohorts. Already what was published suggests that probably one of the major reasons is comorbidity. So various comorbidities in elderly patients, for example, that's the major reason of being difficult to treat. Adherence problems, socioeconomic factors, that's another one, I think, and treatment-resistant disease is probably a third most common. But we really need to see more data from different centers and registries to make sure that what's the most frequent, and the reason that it's very important that if we clarify that what's the particular reason of a patient being difficult to treat, I think it would be more effective, to improve the treatment efficacy if we know the reason, then we just switch from one to another, and that was particularly the major, driving force behind our work, to provide something what might be clinically useful.
Yeah, because
if I may say one, I would say comorbidities, but we will see further data. Yes.
Okay. Oh, that's interesting, because what's so important is, having defined that group, it allows people then to do research studies, doesn't it? And I'm sure that's one of the driving forces. If you define the population, there are benefits of clinical, following the algorithm and doing things in an appropriate way. But now we can do studies in different areas and say, I define this group, and those patients will be the same as in another center. So now we get to look at different research as a result of that. What do you think about that?
I would encourage everyone to do research regarding difficult to treat rheumatoid arthritis and different aspects. And just as you said, we should compare the centers, and so we should compare the outcomes, how this whole concept works, because this was not really validated yet in an appropriate. This is very recent work, so we should see what is in real life. We have a very few publications so far, and it's most weighted to have much more.
Yeah, but now we have the boundaries of a definition, and that always helps enormously, doesn't it?
And we also have the guidance, though. So that's something to test and improve. That's another major project.
So one of the things I was looking at, one of the points to consider of 9 was around having other therapies available. It's the psychologist and other ways of doing this. And one of the things I'm certainly very bad at in the clinics I work in is we don't have available a psychologist. We don't have the ability to refer people for psychological support. Do you think that's something that we're really missing out on, that we should have in clinics? Do you have access to anything like that? So
actually, this is always an excellent point. And when we discussed in the task force this particular question, many colleagues said that oh, we do not have psychologists in the hospital, just as you said. In my hospital, currently we do not have psychologists, but we used to have one, and there's a job opportunity for psychologists, so hopefully we will have. But basically, the task force agreed that only because there are no psychologists, we should not exclude this point, because we believe that this is important. So to have, potential access to psychological support for patients with chronic disease, with especially difficult to treat disease and psychological problems, I think it is important. So we included it, knowing that it's not available in many hospitals, but try to encourage to create a possibility and to create availability of psychologists, and I hope that it will be improved. And so it's not for all patients, but for those for selected patients. I think if you have an RA patients, Chris, probably you have a chance to find a psychologist, don't you? You may not be in the particular hospital where you work, but somehow you can work it out. And this is just the patient path, what I think we should need to work on, and access to particular support, including psychologists.
Okay, so thinking about the pathway and the decision-making tree that you showed, there's a question here from one of our colleagues who sent in a question. And the comment is around, it seems like true difficult to treat patients are in the bottom of the decision tree.
Yeah.
And how would this focus influence the research on this subject? And I guess, is there a true difficult to treat, or are they all difficult to treat? What do you think about that comment?
No, I think I do not see the comment though.
It's in the question. Well, I'll read it back to you again.
Answers. I opened the chat function. Okay. Bottom of decision. See, now I see. How would focus influence the research on this subject? Very good question. So in my view, so we may consider that particular patient populations true difficult to treat, who need a different anti-inflammatory strategy, if you like. So I think that if you go step by step according to our algorithm, starting with clarifying the diagnosis, ruling out the non-real inflammation, adherence problems, comorbidities, and so on, is I think an optimal way to find those patients who really have, not controlled inflammation. So if you do not follow this pathway, you may not identify correctly the patients. You may identify patients with not real inflammation, or with adherence problems, or not correct diagnosis, and so on. So I very much agree that this is just a portion of all patients with difficult to treat. I don't know though how big, maybe less than half of all difficult to treat patients. And I think that, and I hope really that if you follow our clinical algorithm, that you can correctly identify these patients. So I would encourage you to test our algorithm. And from research point of view, it is essential. Absolutely essential.
That's great answer, and a good question from our colleague Peter. So thank you for that. Okay, so I think I'm going to sum up now, if that's okay, because I think we've had some excellent discussion. So I guess what we've tried to talk about is starting off with the theme that was measuring rheumatoid arthritis, thinking about the different scoring systems that we use, recognizing that those are different in different environments, recognizing that they have strengths and weaknesses. And the reason for including difficult to treat in this was the idea that for some of these patients, the scoring system may not always perfectly be able to assess the type of disease. And, I use pain to illustrate that, and we came back to that a little bit. Then we've had the wonderful presentation from Jorgi. So Jorgi, thank you so much for that, the wonderful presentation and your clear answers, and allow us to think about how we define this group of patients who are difficult to treat, to bring some pragmatism and science to how we work our way down an algorithm to work out who is that truly difficult to treat patients, and what different approach that we might have as well as we go through, and then linking that back to measures. And I guess one of the things to the future is, with that knowledge of difficult to treat, is there a way that we might use the measures differently? Is there a need for new measures? And Jorgi did at one stage mention this possibility that perhaps for rheumatoid disease, we need more of a composite measure, which includes other features as well. Okay, so I'm just going to move the slide on. Just next slide, please. That's great. Okay, so feedback is very important. So thank you very much for those of you who ask questions. Thank you for attending. Thank you for being part of this webinar. Thank you to Jorgi once again and to the CSF team for their organisation. There's always evaluation. Evaluation is an important part of medical education and it helps us to make it better. So that would be really valued. And the feedback will pop up, I think, at the end of this particular presentation. The other thing to say is the live stream version of this webinar is now available. It's available on the Cytokine Signalling Forum YouTube channel, so you can watch it back again or colleagues can watch it if they would like. And next slide, please. And here's a little advert. So the next of the monthly seminars is Cytokine Signalling Pathways, Similarities and Differences. So that's around signalling. And I think Peter Nash is the chair for that from Australia. So I'm sure that will be interesting and educational. And then next slide, please. And then there'll also be a webinar, highlights from EULAR webinar on Tuesday, the 7th of June as well, which will look at all of the exciting latest data from the EULAR meeting taking place in Copenhagen in June of this year. Okay, so I think, is that the last slide? Maybe there's one more to pop up, or no, it's back to us both. So it just leaves for me to thank Jorgi once again. Thank you for taking part. Thank you for being such a great colleague to interact with in this session.
Thank you so much. It was my pleasure to work with you and to work with CSF. And thank you so much for the possibility. It was great. So happy to come back.
Fantastic. And thank you very much to everybody for attending.